Hi everybody, I am afraid you will hear what you heard before, a little bit, and that is that nasal polyposis is not one area. It's different diseases. We have to look into endotypes and of course comorbidities, and that has been told you already, but I'll try to figure out with you how we can use these comorbidities together with the endotypes to get a better impression of what kind of patients we actually have in front of us. Early diagnosis would be fantastic, but we all know we cannot diagnose the patient before they come in. But on the other hand, a lot of patients are not diagnosed, although they come in with symptoms, and especially those with lower airway disease are not diagnosed because nobody looks in the upper airways. And that's something where we really have to work on. We know the symptoms, but if you have a severe asthma, you're not so much concerned about your nasal symptoms. And I think that's a mistake. You should look also in the upper airways. We know the symptoms, but what can we do more to improve the diagnosis and our understanding of the patients? And here I am again. There are phenotypes, clinical traits. You can follow traits of a disease, morphology, development, behavior, without any implication of a mechanism. And of course, we as ENTs, I think nowadays, we all ask, is there asthma? Do you have aspirin sensitivity? Where do you come from? Where do you live from? Do you have a fungal disease? And all of these things are actually phenotypes. But what we need to understand is what is playing in the mucosal level. What is the endotype? Because that will give us the possibility to say that a certain patient is or is not eligible for future innovative treatment. These endotypes also allow us to predict the natural course of disease. And finally, hopefully, the response to treatment, but that's something we still have to work on. So that's what we do. Chronic sinusitis, nasal polyps, patient comes in, we want to treat it early. And you have heard here about the discussion, are our current paradigms okay? Should we learn on them? Should we consider when do we what? When do we surgery? When do we what kind of treatment in the future again? And I'm absolutely in favor of that. We should reconsider a lot of these thoughts and our schemes. And really this is a very developing field, especially if there's new medication coming in. But that's what we do. We ask, you have asthma, aspirin sensitivity, cystic fibrosis is a little bit of a separate thing. Allergic fungal sinusitis in some regions, that is something you meet frequently, and I had the pleasure, for example, to be in Saudi Arabia and do quite some surgery there. And of course, this is a totally different disease, phenotypically. What about underneath? Here we state again, these comorbidities are frequent. I will show you in a minute that also from the comorbidities you learn a lot about the endotype. But in general we say, depending again on the region where you live, it might be as low as 10%, it might be as high as 80% of your patients having comorbid asthma. And then there's this diagnosis of aspirin-exacerbated respiratory disease, which I think most of us just ask the patient, do you tolerate aspirin? Did you have ever a story of an event on aspirin? There are very nice diagnostic means, but who does aspirin sensitivity diagnostics? More than a question. 1, 2, 3. Okay, sort of less than 3%. So we should think about in both ways. If you see the patient for the first time for asthma, whatever, then you go up the airways, and if it's the other way around, certainly think about the lower airways. Because we know very nicely, very clearly that the more you have aspirin sensitivity, asthma as comorbidities, the higher, where was the pointer here? The higher is sort of the chance that you have a more severe radiologic score, that you had more sinus surgeries, and that you have more oral steroids use. And look at that, aspirin sensitivity is very high. CRS with asthma is higher than asthma alone. So it tells you a little bit about the combination of the two diseases. But what this slide doesn't tell you is, does it come from the lower airways that because of your asthma you have more nasal polyp and more severe inflammation, or is it the other way around? Because of your inflammation, you get more lower airway disease. And there are quite some factors that talk in that direction, because if you look into the mucosa and the cytokines in the nose, you can actually predict how likely that patient is to have asthma comorbidity and to have recurrence of disease. So it might be the way that we have to look at the upper airways to understand better what is the likelihood of recurrence, but also lower airway disease. Again, no causality at the moment. We have to further work on that problem. But I think you have understood that there are a lot of cytokines playing a role, and that, well, we are not very comfortable with that, right? We learned about CT scanning, we learned about endoscopy, but we didn't learn so much about cytokines. And let's try to make that easy. Whatever mucosa there is, there's an epithelium, and there are a lot of germs on there. We live with them, right? Especially Staph aureus in terms of nasal polyposis. And then there are some cytokines we don't know too much. IL-33 might be the most interesting to learn about, because that triggers from the epithelium down to the submucosal area already the ILC2s, and these cells are very important in maybe switching the whole thing to a type 2 immune reaction. And that type 2 is characterized by IL-4, 5, 13. 4, 5, 13, right? This evening, before you go to bed, 4, 5, 13, right? And IgE. And if you know that, then you understand what makes the B cells drive to make IgE, what makes the eosinophils and the basophils to increase in the tissue, and finally, what drives this whole type 2 immune reaction. Type 2 is the word for that, encompassing all the IL-4, 5, 13 IgE. And that you can translate back into your clinic, because there are patients with no type 2 at all. There's patients with moderate type 2 and severe type 2. This is what you find in the tissue, and that translates to chronic rhinosinusitis without nasal polyps or with nasal polyps. This translates to very little asthma or a lot of asthma comorbidity, 70%. Now, of course, you can use this table the other way around also. So you say, well, this guy has a late onset asthma, very likely type 2, severe type 2. This patient has no asthma, no recurrence, very likely a non-type 2. And again, if you understand what is in your region, very prevalent, you can use these tables in both ways and understand the connection between severity of inflammation and actually expression of disease. There we have to look a little bit into the future, because it would be fantastic to have biomarkers for everything. Biomarkers that tell you this is a type 2, this is a non-type 2, this is the best treatment. Is it this antibody, this antibody? And here we are starting, and we have to bring you more, but there are markers already. Serum periostin, maybe you haven't heard about that. IgE, you have heard about it. SEIGE is something you can measure. Eosinophils in the blood is something you can measure. You can use these already today to understand a bit more about type 2, non-type 2, if, as I said, the patient is not anyway late onset asthma patient. Okay? So to summarize here, the earlier we would understand, we would see the patient, diagnose the patient, understand what kind of endotype that is, the better it would be. And I think we really have to re-evaluate our schemes of treatment and need to go on with better planning. When should I have a patient surgery? When should I have a patient other treatment like monoclonal antibodies? And that is something that will come in the next 1-2 years. We certainly have to look for comorbidity. The inflammatory endotypes correspond with clinical expression, and I try to explain it to you that you can use it both sides, and I think that's very helpful. And of course, there are biomarkers more to come than we currently have, and the ideal biomarker would then tell you how likely is it that the patient responds to that and that monoclonal antibody perfectly. That is what we still have to do. Thank you so much.